So we have now our final talk of the evening, and this is Dr. Gruber from the US as well, talking on limited fasciectomy versus collagenase for Dupuytren's contracture using a propensity score matched methodology. Let me share my screen, and here we go.
Hi everyone, my name is Jillian Gruber and I'm a fifth-year orthopedic surgery resident at Harvard. Today I'll be sharing the results of our study comparing limited fasciectomy with collagenase Clostridium histolyticum for Dupuytren contracture, a propensity score match study of single-digit treatment with minimum 5-year follow-up. In surgical treatment of Dupuytren contracture, limited fasciectomy remains the most widely used and accepted treatment option. A non-surgical option, injection with collagenase Clostridium histolyticum, has been growing in popularity since its introduction. It's minimally invasive, has a low complication rate, and is more convenient as it's done in the office. However, its long-term durability is not well described. There are limited studies directly comparing long-term results of CCH and surgical fasciectomy treatments, and few studies report on patients' perceptions of treatment success in Dupuytren contracture. Therefore, the aim of our study was to compare long-term patient satisfaction, perceived disease recurrence, and reintervention after fasciectomy versus collagenase Clostridium histolyticum. This was a retrospective cohort study comparing surgical fasciectomy and CCH treatment for primary treatment of single-digit Dupuytren contracture from 2010 to 2013. 48 patients underwent surgical fasciectomy at one tertiary referral center, and 111 patients underwent CCH treatment at a second tertiary referral center. We were interested in index procedures on a single digit with Dupuytren disease. As such, we excluded patients with treatment of more than one digit simultaneously, patients who had previous treatment of the affected finger prior to enrollment, treatment for a first web space contracture or lack of contracture, i.e. a nodule excision, and those with less than 5 years of follow-up. At least 5 years after initial treatment, patients were called back and asked whether they received reintervention, how satisfied they were with their treatment, and whether they perceived contracture recurrence. For statistics, two methods were used to control for potential confounding bias. First was propensity score matching, which utilized a probability score of group assignment, i.e. limited fasciectomy versus CCH, based on all included explanatory variables using a logistic regression model. This so-called propensity score was then used to match patients in both treatment groups. Subsequently, imbalance in specific explanatory variables was assessed between groups, and finally, differences in outcome were tested between matched groups. This kernel density plot demonstrates adequateness of matching here on the right. Second, we conducted a multivariable analysis of unmatched data to account for potential confounders. Finally, we performed stepwise backward multivariable linear regression analysis to identify factors associated with patient satisfaction in each group. 180 patients were identified who underwent surgical fasciectomy. 67 were excluded for more than one digit involvement, 21 for prior treatment on the affected digit, 2 for nodule excision only, 3 had expired, 6 had no phone numbers on file, 24 were unable to be reached, and 6 declined to participate. This left us with 81 patients, of which 63% responded. 3 additional patients were excluded due to missing outcome variable data for a final cohort of 48. 261 patients were identified who underwent CCH treatment. 63 were excluded for more than one digit treated, 25 for prior treatment of the affected finger, 4 for web space involvement only, 21 had expired, 10 had no phone on file, 7 couldn't be reached, and 16 declined to participate, for a total of 148 patients for whom follow-up was attempted. Of these, 115 were enrolled, and 4 more were excluded due to incomplete outcome variable data. This left us with a final CCH cohort of 111 patients. After propensity score matching, there were 44 patients in each group, and there were no significant differences in any baseline variables. Mean age was 68 years in the CCH group and 70 years in the fasciectomy group. Average length of telephone follow-up was 7.3 years in the CCH group and 7.4 years in the fasciectomy group. After propensity score matching, bivariate analysis demonstrated that perceived recurrence and reintervention rates were significantly higher in the CCH group compared to the surgery group. It also showed that median satisfaction was significantly higher in the surgery group than the CCH group. Non-matched multivariable analysis of outcome measures demonstrated the same statistically significant relationships. CCH treatment had increased odds of recurrence and reintervention compared to surgical fasciectomy. Stepwise backward multivariable linear regression analysis demonstrated that isolated MCP disease was associated with higher satisfaction in the CCH group, and diabetes was associated with lower satisfaction in the fasciectomy cohort. Patients who underwent surgical fasciectomy were more satisfied at 7-year follow-up than those who received CCH. At an average 7-year follow-up, we found a reintervention rate of 50% for CCH and 16% for surgical fasciectomy, which closely reflects a study by Leafblad et al. Difference in reintervention rate after surgical fasciectomy may be due to our longer follow-up duration, surgeon differences, or patient preferences. We found an 80% perceived recurrence rate for CCH treatment compared to 15% for fasciectomy. This is higher than what is reported in the literature, which may be attributable to longer follow-up in our study and patient perception of recurrence as compared to objectively measured recurrence. Studies by Pimer et al., for example, had lower recurrence rates, 35% at 3 years and 47% at 5 years. However, they had shorter follow-up, and they defined recurrence as 20 degrees of worsening of a patient's index contracture. Recurrence rates after surgical fasciectomy range widely in the literature, from 0 to 73% depending on follow-up length and definition of recurrence. Our perceived recurrence rate of 15% falls within this range. We also found that isolated MCP disease was associated with higher satisfaction after CCH treatment, which is consistent with prior data that shows greater durability of deformity correction at the MCP joint compared to the PIP joint. Finally, we found that diabetes was associated with lower satisfaction after surgery, but this should be interpreted with caution as there were only 3 patients in the fasciectomy cohort with diabetes. So in conclusion, long-term patient satisfaction was higher with surgical fasciectomy than CCH treatment. Patients may be counseled that long-term CCH treatment has approximately twice the rate of perceived disease recurrence and 3 times the rate of reintervention compared with surgical fasciectomy. As such, it's important to counsel patients not only on short-term recovery, but also on long-term durability of treatment options.
Thank you. An excellent presentation there. And I'm just going to promote Dr. Gruber up to panelist. She's flying through the air at the moment. Arrived on our virtual screen. Welcome.
Hi, thanks for having me.
It's a pleasure. Thank you for joining us from all the way over, well, the other side of the pond from me, certainly not from Gary, just up the road from Gary. So we don't have any questions from our audience. Our panel, do we have any questions? Gary, you're first with your hands up. I'm sorry, you're on mute.
I thought your paper was excellent. Obviously have an allegiance to Mass General and Harvard, personal allegiance as I trained there. One question I had, I mean, I know that the collagenase studies were done very early in the use of collagenase. Do you think that if 2 doses of collagenase were used at the same time as we do now, and you would not have been able to do then for MP and PIP joint contractures, or skill level for some of the surgeons using it might have made a difference in some of the numbers?
I do think that's possible. That's one of the limitations that we discussed in our study as well, since this was done, we looked from 2010 to 2013 at this point. So I think that there have been advances and that may have impacted the results of our study.
Congratulations on the publication as well.
Thank you.
We've got a question from Keith Denkler, who wants to know, again, this is sort of related. What was the dose of collagenase that were used in the patients in your study? Was it 0.58 or 0.9 milligrams?
I believe it was 0.58.
They were using the standard dose, FDA prescribed 0.58.
Absolutely. Okay. And David Hunter Smith wants to know, if you were a mad keen golfer, and wanted to enjoy your life as much as possible, what treatment would you choose for your Dupuytrens? Would you go for the quick fix but higher recurrence, or would you go for the longer durability?
I think, that's an interesting spin to have on it. I'm not a golfer, but I think that probably the longer durability is what I would be inclined to go for. Patients seem overall more satisfied longer term with this. But I also think that obviously with collagenase, it's a pretty low risk and pretty quick recovery time. So there's not a lot of downsides to, I think, trying that first and seeing if it works as well. Although in our study, we only looked at index procedures for comparing these two groups.
Okay, thank you. And John Barhorst is a patient who's had a needle aponeurotomy and just wants to know about what the recovery was like for your fasciectomy patients. How quick was their recovery?
So it's a good question. We did not look into the specifics of recovery times or even complications with this paper in particular. We were really interested in long-term follow-up, more than 5 years. So it was pretty standard, but it's not something that this paper really looked into. Okay,
yeah. And another, I think from a patient, Patrice Smith, you're suggesting that the surgical procedure is a better choice for the patient potentially in the long run, but is there any consideration of the age of the patient when you're recommending surgery versus other treatments?
Yeah, so we, in our study, we did not find that age was a factor when comparing these two groups, but I do think that it needs to be a informed decision-making process between the patient and the provider, because surgery is still surgery at the end of the day. So if there's someone who is older with more comorbidities, that's undergoing more of a risk for undergoing an operative intervention. But we did not find in our study that age was a factor in outcomes between the two groups. Okay,
okay. And I think Gary is typing an answer to Mark Purcell, so I'll leave that one running, and we'll ask the final question from Ivan Sergeyev. A recurrence with collagenase has vastly different implications than a recurrence after surgery. So suggesting that recurrence after collagenase isn't really a big deal. What do you think about that?
I think that the recurrence rate, I'm not sure if I fully understand the question. Let's see.
I think what he's getting at is that if you have a recurrence after collagenase, well, you could have another collagenase, or maybe you could have a needle and the scarring's not so bad. Whereas if you've had open surgery, then treating that recurrence is much more difficult than treating after a minimally invasive procedure.
Yeah, I think that that's a good point. And probably one that would be best addressed with future studies looking at these two approaches and recurrences. In our study, one of the well, not really a limitation, but something we didn't look at was treatment of recurrences. We just looked at index procedures and what those outcomes were like.
Yeah. I think all of these come into the discussions that we have with our patients about the short-term benefits versus the longer-term risks. Paul, would you like to make a closing question?
Yeah, and I just would like to echo something that David Warwick told us some time ago. He said that although you can treat recurrences with collagenase again, if you thereafter embark on surgery, it is sometimes really a nightmare. Not always. Some people have described it to be very easy, but others have described it to be extremely difficult. And as I said, I'm only echoing what he said, and that is something that we have to be aware of.
Okay, Gary, one final thing, because we're just over the 2-hour mark.
Just to follow up to what Paul just said, I think that waiting about a year after collagenase will make an open surgery procedure easier. I think the people that had the most difficulty were going in and doing a fasciectomy 3 months later, 6 months later. We've had this discussion at multiple conferences. And I think that somewhere around the year mark, it starts looking like a regular cord again. So I would discourage anyone from operating quickly on a failed collagenase.
Okay, so on that note, it just leaves me with the happy job of announcing the winner of the prize for the best free paper. And Dr. Gruber, I'm pleased to say that you have won that. The International Dupuytren Society will be in touch with you. It was a close run thing. There was only 1 point between you and Dr. Motoroko in the scores. So they were both very good papers. I enjoyed both of them. But our judges just awarded the prize to you. So thank you very much. We'll be in touch with details of the prize shortly. Thank you to all of our attendees, and thank you very much to our panelists. I think it's been an excellent couple of hours talking about Dupuytren's disease. Please remember to sign up for our subsequent webinars. So there's one coming up in 2 weeks on classic surgical approaches, where your keynote speaker is Paul Verker here. And that's going to be a fantastic talk. And we have some more free papers and another free paper prize as well. So thank you very much for attending, everyone, and we'll see you in 2 weeks.
Thank you.
Thanks
Thank
so
you.
much.